Hello and welcome to AI Amplified, Healthcare AI Discussions with Dr. Heather Bassett. AI is here, it's real, and it's making a major impact. Dr. Heather Bassett is Chief Medical Officer at Exelis and is at the forefront of innovation, cutting through the noise with other industry leaders who are making a real impact in the world of healthcare AI. AI Amplified is brought to you by Exelis, an AI-driven healthcare technology company transforming the payer-provider dynamic. Let's give a warm welcome to healthcare industry champion and our host, Dr. Heather Bassett.
Welcome, everyone, to AI Amplified. On today's podcast, I'd like to welcome Rom Eizenberg. Rom is the Chief Revenue Officer and Head of Product Innovation at Contact.io, where he leads efforts to transform healthcare operations through an intelligent orchestration platform. With over 2 decades in enterprise software, digital transformation, and startup leadership, Rom has held key roles at Hewlett-Packard, HID Global, and Blue Vision HID, and is a founder of 2 technology ventures. Educated in computer science and international economics and holder of 3 patents, Rom is passionate about designing innovation, human-centered solutions that improve patient outcomes, staff productivity, and hospital efficiency. Ron, welcome to AI Amplified.
Hey, thanks for having me, Heather. Good morning.
Good morning. So interesting when I was, reading your bio, educated in computer science and international economics. So that's not a typical combination that you see. Kind of what kind of garnished your interest in computer science and also kind of international economics?
I mean, I think generally my career journey was a non-standard one. You usually find people in the business side of the of the house, coming from economics, MBAs. We are usually lazy. We don't like to study too hard as salespeople. And then engineering and product comes from a very different pathway. I think that mine came from a curiosity around how things work. As a child, I always like to open things up, dig behind, and see what's inside. And I think I evolved over time to discover that bridging technology to human beings is really what I do the best. And that was a very useful trait in my career as an entrepreneur and usually, starting with product and very quickly moving to the business side of making that product available and useful for many people in the world.
Yeah, I think that's great because, if you think about kind of that more engineering, computer science, or just kind of science in general background, a lot of it is asking questions. And, in your current role with not only kind of from the sales standpoint, but probably more so product, a lot of it is about asking questions within healthcare so that you can, design the next best, whether it's AI driven or not, product in that space. Now you've been with Contact for, I believe it's 6 years now. So how did you get into really into that healthcare space?
I've always been living in the intersection of hardware and software. How do we give computers access to the real physical world? And today, that's a hot AI topic, world models, you name it. But 10 years back, nobody was talking about AI, but it was very clear to me that the gap between computer software and the physical world where we live, where things actually happen, when things have shaped, some things that our Z-Gen children are not exactly sure about. Right? They were born into a digital world. I am an X-Gen old fella. When I was born, we had computers, but they weren't very smart. And we were running around and playing ball. So bringing that notion into IT and technology and better connecting the dots was always my journey. And there was a moment where we realized that out of any industry, we could help and dive in and see how we can solve problems for healthcare absolutely comes up on top. It's the largest segment in our economy. More people work in healthcare than in any other industry. If you want to know who is the largest employer in any state in America, open up the company register, and it will be a health system. All of us end up meeting at the ED, rich and poor, smart and less smart. We all get together in the ED, and the people who work there have to deal with all of us. So it's a promising industry, not so sensitive to economic turn ups and downs. There is a critical need, and I think where we found most passion is the realization that healthcare as an industry has been investing heavily into the clinical outcome side of the hospital. In other words, hospitals are run by doctors, and doctors love to buy toys that make their patients better, which makes perfect sense. That's the right thing to do. But over the last 30 years, if you really look at where money was spent, it went to that front of the house type of investments, leaving the operation of delivering care, the non-glamorous, nothing shiny about delivering care. It's about running up and down corridors, getting a glass of water to a patient, making sure that the syringe pump that is missing in the department finds its way to a patient room, because without it, we can't administer pain medication. Almost everybody that works in a hospital are involved in delivering care, and that is a domain that has suffered from neglect, lack of investments, and really is probably, if you compare that to how we see, automakers like Toyota building cars, their operational side of the house is light years ahead of where we are in healthcare. And I used to joke that, if the Mayo Clinic was building a car, you will get a Toyota Corolla for $150,000, and they will be losing money. So that is a big challenge to fix, and I love big challenges.
Yeah, no, you're spot on. I remember when I first started working with Exelis, and I had pretty good understanding of operations from a physician standpoint, having worked in the hospital. But when I was introduced to utilization review, I think I visited every basement in the hospital because they were kind of hidden away. There weren't the tools that as you mentioned. A lot of things are built, physician facing. They tend to kind of get the shinier toys, but the hospital doesn't just run on the physician workflow. There's so much that happens in the background around that patient orchestration. And I remember getting frustrated as a physician of why is my patient not, being transferred to get their MRI? And it's because, nobody's available to come pick them up. And if you go to Contact's, website, there's, clearly you have leaned into the AI space and even into agentic AI. But my understanding was that's not, when you joined the company back in 2020, there wasn't as much, AI in place. So were you kind of part of that, working with the team of, recognizing that AI could play a pivotal role in this space?
Yes, and it was an exciting moment because it helped us do things we always wanted to do. Mm-hmm. Let's use a very simple microeconomic model. We all know it from our undergrad, demand and supply. And if you think about care, demand is generated by a physician. So a provider walks into a patient room, observes the patient, talks to him, examines him, and makes a clinical decision. That decision is logged in Epic, Cerner, in your EMR system. Once that happened, we created demand for care delivery services. Before that physician entered an order in Epic, we know nothing. We know nothing about the patient. We know nothing about the health of the patient. We are in a waiting period until a provider enters a record. That creates demand. Behind this record, there are people running up and down corridors, grabbing equipment, bringing the drugs from pharmacies, doing what it takes to help us make the patient better. And the demand side and the supply side of the house, if supply would be all of those people we hired, all of those medical equipment we bought, all of the clinical space we acquired with the building, then matching demand and supply is something that hospitals never really did. First come, first serve is the rule of the house. When priorities change, we just grab the next one in line, or sometimes the guy who shouts the loudest. If you are a hospitalist, then your greatest skill is probably not medicine. It's fighting fires. It's getting people to move and do things. And your best tool of the job is the phone. We pick up the phone and we call the department. We pick up the phone and we call transfers. We keep up the phone and we call a cardiologist and ask for an urgent consult. We just talk to people and make things move. And in 2026, that makes absolutely no sense. There is so much lost when humans are trying to do coordination without data. It's almost like running an airport without a control tower, without having a radar. Nobody knows what airplanes are in the air and how much gas they have. If you are a hospitalist, you just deal with the crisis in hand. You need an ICU bed. You need it right now. There is an ambulance coming. A new customer is about to hit the ED, and you are short of a bed when you're going to need it 3 hours from now. So that's your main task. And when we started Contact.io, we were able to create all of the data that describes the supply side, what you have. We can see the patient moving through the care delivery process every second of their stay with us. But we don't understand the demand side because that lives in Epic, two completely separated silos. We are waiting for someone to tell us what to do. What AI allowed us to do for the first time is match demand and supply and consider, and I mean, basically do that simple act we call reasoning. It's all bounded, right? There is no hallucinations here because it's not an AI that is a chat GPT and we talk to it and we ask it, and it tells us how smart our ideas are. It is a benchmark system that knows to evaluate the set of priorities and the set of opportunities it has in hand, matching the best resource to the best problem, subject to what's most urgent, what's more impactful on patient length of stay, on patient experience, and clinical outcomes.
Do you guys have, because you have to have a tremendous amount of data, and you utilize that data to drive your products, to derive decisions, derive how your AI agents end up working. But did you kind of start with some kind of predictive machine learning models initially, and then you still take advantage of those, or if you move just fully into kind of agentic AI and allowing the agents to access whatever different types of tools they're accessing to orchestrate the workflow?
So I want to say that there are all sorts of AIs, right? AI comes in flavors. Mm-hmm. Some of them very ancient. Computer vision, which was probably the first way we used AI to interact with the world, is now very sophisticated, very advanced. We have cars that use a camera to drive on a road, and even in New York City, where we have delivery guys driving on electric bicycles against traffic in the dozens. The camera is good enough for the computer to navigate. So in my world, the first challenge we had was data, is understanding the supply side of the hospital. Who is on shift? Where are they? Are they busy? Is an infusion pump in a patient room and being used, or is it in a corridor and it's just soiled and standing there wastefully? Which delivery or transport operator should get assigned the next task? The person in the 5th floor and the person in the 4th floor. It depends where the patient is. So understanding the resources side was the first challenge we tackled. That doesn't require AI. We ended up using a technology called RTLS, real-time location systems, and this uses Bluetooth radio waves, and we are tracking the location of everything that moves in the hospital, including the patient. Now, that immediately created a wealth of data we never had before. Think about it. When a patient stays in a hospital, an acute stay, typically 4.6 days in length, what do we know about that stay when the patient left? We know only what people manually wrote in an EMR system in the clinical record. And since this is people-generated data, it is not necessarily accurate. It is absolutely not timely, and it is sparse. We don't have a lot of data entries. It's not rare to see a patient, after 4.6 days, and we have maybe 30 or 40 records. In the world of RTLS for Contact.io, when we look at the supply side for a 4.6 day patient stay, we have millions of records. They are all very timely. They are machine generated. They are all accurate for their own right. In AI, and we always talk about data, AI loves machine data. It needs a lot. It needed to be plentiful. It needed to be timely. It needed to be accurate. And it's not that human data is not useful. The data that we have in the EMR gives us context to the machine data that the location system generated. So EMR data context, real-time location gives us the operational reality of where everything is, how everything is being used, who is working with who. Oops, that was a bang. And by meshing them together, we can start making decisions. So for us, the first step, creating useful data. The second step, contextualizing the data. The third step was to basically predict the future. And it turns out that predicting the future is not as hard as you would imagine, because we have a high degree of repeatability, what in many health systems today call service lines. So our cardiovascular bypass patients are alike. They're not the same, of course, but they are alike. And by standardizing over clinical workflows to similar patients, we actually save life. We improve clinical outcome. We reduce lengths of stay. We are taking a similar approach, and we are saying, well, if we see a patient that is 65 years old and is complaining of severe chest pain and difficulty to breathe in the ED, we can start drawing a forward path that has forks and probabilities. That patient might go home in half an hour, but more likely we will keep them overnight for observation. That patient might require surgery, but more likely not right now. If that patient ends up in surgery, we can already predict what this patient will need after surgery. Not just a PACU bed and an ICU bed, but we know that if patient was in surgery for 6 hours, typically within 4 hours after arriving in the ICU, this patient will see a provider. This patient will receive pain management. It's just very common. And if that's the case, why can't anybody at the hospital make sure that we have a syringe pump waiting in the cardio ICU 4 hours from now when this patient arrives and is being administered pain medication? Why have that nurse react to a demand she didn't see coming, running down to the ED to find the pump because she doesn't find it in the department? It's those little things. It's a death by 1,000 cuts, each one extending length of stay, damaging the cost structure, the operating efficiency of the hospital, and creating bad experiences for patients, creating burnout for clinicians. And we feel that we are in this unique moment in time where the combination of data, context, and reasoning allows us to really make a dent in how hospitals are running care delivery.
Yeah, it's amazing when you think about length of stay, particularly from the hospital perspective, and the longer a patient stays, whether they're avoidable delays or other reasons for that, increasing their length of stay, the cost associated with that is huge. And even moving the needle a little bit, I mean, we're talking less than a day movement creates tremendous revenue opportunity for the hospital. And also
impact on access, right? And impact on access, because that bed being freed early means that a new patient can occupy it, and we can reduce waiting time for surgeries and provide better service to the community. It's not just money.
Yeah, and it's also, you brought the patient in because it's easy to think of it just strictly from the hospital operations standpoint. I also love that you said hospitalists half the time, they're not concerned about the medical part. They're more dealing with putting out the fires. And I kind of joke that there was a lot of things that were not explained in the medical school brochure when I signed up to be a physician. You didn't realize all these other things you're going to end up having to do that weren't value add. But the patient experience is huge, and we're all patients at one point in time, and you don't realize what is happening in the background that's creating all of that friction that you as a patient are feeling on, like, why is this taking so long? Why do I see all these empty exam rooms, but I'm still waiting? So it's I like how you kind of put the context on both pieces. It's not just the revenue associated with the hospital, but it's also the patient experience. And you kind of touched on this, and I'm curious your thoughts in general. So when AI is everywhere, and now the latest thing is agentic AI, and when you think like from a product standpoint, when you think about agentic AI, it gives you the opportunity to kind of improve the system, right? Because it's very human driven these days. But when you layer in agents, you can kind of reimagine what a better workflow is to gain that operation. And I kind of I worry a little bit, and I think that a lot of companies aren't taking that approach. So they're basically using agents to recreate human workflow, and then we're not really going to move the needle. We're just putting more costs in the system. So I don't know how you think about that, particularly when you put your product hat on.
I have a funny story. So we were hiring a corporate counsel. Our company is lawyer, and I was taking part of those interviews. And there was a very intelligent candidate, and I couldn't help myself, and I asked him a very similar question to the one you're asking me. I told him, listen, AI is coming to take our jobs. Why do I even have to hire a corporate lawyer? Contracts are so standards, and I've seen AI agents redline commercial contracts, do it very well, efficiently, quickly. Maybe we'll have agents negotiating with agents, and that was the question I posed to that poor candidate in an interview. Why should I even hire you? And he gave me absolutely the best answer. He said, listen, 30 years ago, if you walked into an accounting office, then you would see 40 usually elderly ladies sitting there and doing data entry and consolidating the books and copying log transactions. And then Excel came and made all of that work unnecessary. So, and then he posed me a question. He said, what do you reckon happened to the employee count at accounting firms? And I said, well, I would expect it dropped dramatically. All these people lost their job. And he said, well, but if you really look at the data, then we have today 8 times more accountants than we had 30 years ago. It actually didn't change any human. It's just made humans more efficient, allowing them to do more work faster, but then the work grew. I'm not one to predict the future, and I can't say how it applies to AI or not, but I have a good sense it does. I think the goal is or at least how we think about it in Contact.io, is to take away the stuff, the work that is mechanical, that is boring for you. You do it because someone has to do it, but you don't create value in doing it. And and free up your time and your attention to focus on what's really important. And it's a silent killer. And many times it's very hard to measure the lost impact of an employee, what they didn't do for us because they were chasing, details and phone calls, and then the leg of the chair was broken and they had to go and find a new chair. It's not something the CFO captures. And then freeing up this time from answering phones or running around with your tail in fire to actually taking a step back, thinking for a second about your day, your problem, a challenge, sometimes have tremendous effect. And those are hard to measure, but we're really seeing the beginning of that impact. So productivity savings. We are not going to let people go. We are actually going to make people busier. We are just trying to take away the things they don't like doing and do it for them.
Yeah, and I agree, because if I think about when I was working as a physician in the hospitals, or even my day-to-day as it is now, there are multiple things I would love to have off of my plate, because they're kind of low value versus more kind of clinical thinking or strategic thinking. It'll be interesting kind of what that line is of taking tasks off, because you're increasing then the complexity of tasks that you're asking the human to do. I was at a conference once, and I wish I remember who said this, but they were talking about that same thing, and it was around radiology reports, and they're like, oh, the AI can read all of the simple chest X-rays, and then the physician will just read all the complex ones. But the advantage of having a simple one every once in a while is your brain gets a break. And I thought about that from a physician standpoint of like, seeing a patient in the ICU that's really sick, seeing a patient in the ICU that's really sick. And then, a patient that's not as sick and, kind of a bit more straightforward, your brain gets that a little bit of a break instead of always being in that on state. So it'll be interesting, as we move forward in this space, what that line is, so that you actually don't end up overtaxing, our employees, at whatever level of work they're doing.
I think that one of the challenges is how we do work is driven and influenced by the capabilities, but also shortcomings of computers. So the idea of workflow, the idea of a sequence of activities, one leading to the next in a rigid structure, is a computer software kind of thinking. And it's also the limitation of computer software. That's all we could do. If then. And today we have computer software that can deal with irregularities. In a way, if you want, when a task hits our agentic AI, by default, we don't use AI at all. We're trying to determine what is the best existing workflow that fits that problem or that request or that piece of data. And we use a repeatable workflow, because in life, 90% of the time, 90% of our problems are repeatable, and we know them really well, and they're well solved by a sequence that we standardized on. But sometimes that's not the case. And when it's not the case, troubles begin. And it's fascinating. It's also a challenge for humans, because when we hire humans, we don't train them to think. We train them on our workflows. We are actually, I'm saying that with a good sense of humor. We have been turning humans into AIs for the last 30 years by telling them, don't think, do A, then B, then C, and if it doesn't work, escalate. Go to your manager. Don't try to solve it. Just ask someone. So in many senses, our AI works like a new employee. We tell it, always do the same. Don't use AI. Don't think. But if something doesn't work, we escalate to an agent, to an AI agent that can reason through the problem. And then actually, and maybe I'm opening, a look under the hood, the agent rewrites the workflow. So we have agents coding workflows to match what they've just learned from an exception that we never ran into before. So the response is highly repeatable, zero hallucinations. This is how we work in this hospital. This is our process. And when we run into irregularities, and as you and all the listeners that live and breathe healthcare every day, irregularities are the rule of the house. We have our plan. We have a staff meeting at 9 a.m. We have a plan for the day. By 10:30, the plan is out the window, and everything changes. And dealing with those changes, is where we use agentic AI, right, to measure and decide to optimize what we previously planned. But surprising for me, humans are not very good at doing that anymore. And I think the blame is on us. As a society, we are training humans to think less, to do repeatable things, to escalate when they are not sure. And we are losing that capability to make, to use our common sense, to use our analytical capability and make the right decision on the spot.
That's it. I'll have to remember. That's an interesting way to think about things that we've almost, kind of dumbed people down by having them, do A, then do B, then do C, and don't deviate. Because when you hear, there's, the press, they love to kind of anchor on those kind of edge AI cases and kind of the very negative things about it. And AI is going to take everyone's job, and AI is going to do this. But if you think about it from that perspective, you could almost see how it could open the door for more creativity, more innovation by kind of allowing humans to have that space. I think that's a very interesting concept. I know we're coming to the end here. So I'm curious, I think things are going to change quite a bit in the next, even 2 years, let alone 5 years. Is there something you're kind of pretty excited about or what you're hoping is going to happen in the next couple of years?
I think that the most fascinating change that is coming our way is actually the robots. It's a quiet revolution. We all have seen some video on Instagram or on Facebook of some Chinese robots, doing karate. It's more of a funny anecdote right now, but in reality, what is happening is that an entire industry is emerging, and the most interesting ones are the humanoids, the ones that don't require us to retrofit the real world because they fit anywhere humans fitted before. BMW, I think, has 2 factories with 24-hour shifts by humanoid robots doing paint jobs and building cars. Is this coming to hospitals? I'm not sure. I hope not. I can say that right now, I don't know of a single health system out of our customer roster that doesn't have some sort of a robotic pilot in the air. Virtually everybody. We see a lot of, meds to beds, so pharmaceutical deliveries, maybe biomed, medical equipment delivery. So limited use cases, but the creatures are driving in corridors in American hospitals already today, and these pilots are everywhere. So what does it mean in the next 5 years? I don't know, but it's definitely fascinating. I still have a very strong opinion about the human interaction with other humans, the human relationship. Nothing can change that, and especially in care.
Yeah, I agree. It'll be interesting to see how robotics plays out in the hospital. And you do, to your point, see it today in delivery of drugs back and forth to the pharmacy or other pieces of equipment, and they like to kind of make cute little faces on them so they look not non-threatening. But I do think there is something sacred, particularly when a patient is ill, and having to make some challenging decisions. But there is something sacred between the relationship between I'm a physician, so between a physician and a patient, that I don't think you can't replace that with a robot, nor do I think we should replace that. So yes, that will be interesting to see how that plays out. Well, thank you, Rom. This has been some very interesting conversation today, and definitely things to think about. Obviously, Contact is being very thoughtful of in particular everything that's happening behind the scenes at the hospital, and improving not only hospital operations, but the patient experience as well. So thank you so much for joining me today. You can stay in touch by connecting with Rom on LinkedIn. That's RomEizenberg. Follow his work with Contact on LinkedIn, or go directly to their website to learn more at kontakt.io. You can find all of these links in our show notes. Thank you to our listeners for joining us today. Until next time, I'm Dr. Heather Bassett, and this is AI Amplified.
Thanks for listening to AI Amplified. Tune in to the Healthcare Now Radio Podcast Network for more episodes like the one you heard today. To learn more about Exelis, visit our website at exelis.com. That's XSOLIS.com. You can also follow Exelis on LinkedIn, Facebook, and X. Dr. Bassett would love to connect with you. Join the dialogue on her LinkedIn, where you'll find her at Heather Bassett, MD. Let's keep the conversation going.